patient outcomes start with the right technology partners. JB Consulting helps pharmacies deliver superior clinical care and enhance patient experiences through smart technology solutions. Our products help pharmaceutical manufacturers improve patient access and build stronger pharmacy relationships. JB Consulting, where pharmaceutical expertise meets cutting-edge technology. Visit jbconsulting.com.
You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
Each year, Asembia's Specialty Pharmacy Summit is at the epicenter of the pharmacy industry, providing a unique opportunity for stakeholders throughout the industry to understand challenges, generate solutions, and define the future. This is the Pharmacy Podcast Network's Asembia 2026 Rewind. We're dedicated to bringing you inside coverage of the pharmacy nation's biggest events, with on-the-street style interviews, with keynote speakers, attendees, exhibitors, and recurring guests who make each year special. Stay tuned each week for a new episode of this special 6-part series on the Asembia 2026 Summit, held this year in Las Vegas.
Hey, Shaun Jensen here from the JB Consulting Group, and you're listening to the Pharmacy Podcast Network.
Shaun, Jensen, how are you? It's nice to see you.
Hey, Todd, so good to see you too.
Why do we only get to hang out when we come to work? Like, you and I never get time to just go get a drink or watch a ball game or something. Like, we're always working.
Yeah, but that's actually going to change. It's going to change this in May, actually. I'm coming out to Pittsburgh area for a couple of days for a customer I'm working with.
Nice.
So, yeah.
All right.
Big announcement. I'll be hanging out.
Hanging out in Pittsburgh.
Breaking news right here.
That's right. All right. So I want to know, we're really focused on really 3 core themes during Asembia, during the podcast press coverage. Women's health, cell and gene therapy. A shout out to Joe DePinto with McKesson. He did an amazing job. And AI in specialty pharmacy specifically. So that's why I was so excited that you were coming back to the show. You've been a reoccurring guest over the years, always at Asembia, at NASP, even on Twerks. But talk to me from your perspective, because that's all you guys are really doing right now, is what's your advice to the first-time attendees in those, like they're wondering the halls here, how to get the most out of Asembia?
Yeah, I mean, great question. I'll say in terms of the hall here, this where we're sitting, there's so many vendors right now. I think it probably got to be overwhelming for not even a first-time attendee, anybody here who's trying to decide like which of these vendors to partner with, which of these AI companies to go with. Are they going to be in business a year from now?
Yeah.
Like, there's so many unknowns, and just walking by and reading the signage, it's not totally clear, what some of these companies are even doing here. It's like, I could see it be really overwhelming. So I would just say, take the time to listen, talk to them, but find out who they're working with, talk to the customers, talk to their customers, find out, because everyone here is selling the same stories, solving the same problems, and a lot of these companies are really new, like you're seeing, Todd.
So the pharmacy management landscape has been condensing. However, there are still gaps in many of the systems that are out there that the pharmacy has needs either in workflow or something that communication with the patient or something. So tell us about the pharmacy management system landscape from your perspective and how JB Consulting fits into that.
Yeah, I mean, great question. The really, with the consolidation that you said, the narrowing, on the retail side, it's 80-90% market share now under Red Sale. There's a couple other, large price ticket, other alternatives. No matter what you pick, you're always trying to stitch something together. You're always adding something to customize it. Some people feel nickel and dime when they have to make customizations. Even if you're willing to pay, you're getting a long line a lot of times. So, nothing's perfect. And some of the lower end systems, the price point's almost zero. It's negligible. But like, what's free? You know, you got to ask yourself, like, how much time is being wasted by your team, and how many workarounds and band-aids are you putting on? How much just human labor do you put into to solving these problems? So, one thing JB has done, we have built, because people, it's the buy or build. Everyone always wants to know, like, what system should I go with? And we'll help migrate between systems. You know, we're agnostic, whichever platform you're going to or coming from. You know, we're happy to help manage that integration process, but we've built pharmacy systems. So even some of these companies that wish they could build their own, they don't even know where to start. They know it's going to be millions and millions of dollars. You know, it's not. We have like white label solutions that people have bought, and they're modular. And you know, for the most part, a lot of it's a commodity. Like most of the stuff that goes through that system they're the same between all of them, and that's what, you know, we've already built that for 20 years, building things like that. But the customization and who you integrate with, what partners is integrating with. So that's where having that flexibility, really build it yourself. And at the end, you can own the source code. I mean, it's really an interesting choice. You know, and it really came from a demand. People were asking us, you know, we want to build this system, but it's just overwhelming. Where do we even start? And that's something JB's been helping companies do, you know, kind of quietly, and it's white labeled. So if anyone out there is listening, they want a pharmacy management system. It's not as big an endeavor as you might think, and, you know, take control of your operation, do whatever you want, you know. So
maybe reach out and at least just ask questions. Reach out to JB Consulting Group and just be like, hey, here's what I want to do, here's what I've already invested in, here's the tools I already have. Is there a way to build something different for us? Because maybe you're doing long-term care at home, infusion, and a little bit of traditional LTC, DME, who knows? But there might be gaps in your system that you have an opportunity to solve that problem for them. And that's what you guys have been famous for, really, over you said last 20 years of being in business and developing software. Our theme is AI and specialty pharmacy. So since the last time that we talked, what's come up? What's happening, or where are we shifting to, or what's a success story that you can share with us regarding AI and specialty?
I mean, I think it's interesting. You're seeing adoption. You're seeing people automating low-level tasks, obviously. You see a lot of vendors here helping to do that. But interestingly, you're not seeing the decline in headcount. So it's not like, hey, we were able to automate 50 hours, so now we don't have techs anymore. Now we don't have, you know, we got rid of 2 of our best pharmacists. And you don't see any of that anywhere. So people are still trying to figure out, like, all right, they're saving time. Are they like using that to reinvest that time? Which is what the hope always was. I don't want robots replacing pharmacists, replacing people. If it can take some of the job away and make other parts better, sure. But like something like as a society, like the larger things, not to get too deep, but like the other concerns with AI, they're obvious, like telling you to put glue on a pizza to keep the cheese on. Yeah. Some of the scary, dark stuff that's coming out. That's where, like, to me, I like the automation, like, hey, read this 100-page document and tell me what it is. Like, I got a weird credit card statement thing that was 8 pages long. I just took a picture and was like, is there anything I need to know about this? Just out of curiosity. And it was like, no, not really. So sure, AI is good for that, but making decisions, advising people, like, I don't know. That's where it gets scary in any industry, and like especially with healthcare. So we got to be really careful where we're treading with it. I'm not a doomsday guy or anything like that by any means. But that's, I think once we cross that area into advice and guidance, that's where things are going to go off the guardrails, at least initially, and we'll see what happens. I mean, what do you think?
Well, I know that AI is impacting humanity in general already, where there was a study, I can't remember who did it, but the generational study of intelligence, it's the first time that the latest of generations are less intelligent based on a measurement than the last generation, and they're all tying this back to people, students, children skipping steps because of the accessibility of information. Yeah. And not to sound like I'm the old guy in the room, but really, when I had to do a book report, when I had to do a research project, I had to physically go to the library, go to the Dewey Decimal System, for God's sakes, look up the book, go find the book, sit down, read, take notes, and develop my report. That taught me something about research. That taught me something about information. We have lost that component of learning, and I think quick to everything is not good in all senses. I think when you remember the old movie The Karate Kid, right? And Daniel LaRusso, right? He had to do the same action where he was paint the fence up, paint the fence down, paint the fence up, and he had to do it in a specific way. He wasn't allowed to just do it however he wanted. And he didn't understand, why do I have to do this over and over and over again? Then all of a sudden it was put into action, and he's like, holy cow, I just blocked. It was like a crane style block. Like, I understand now why that was necessary. Throw AI into that, I mean, even into martial arts, and you're going to get your ass kicked because you've shortened the process of getting to a conclusion. And I think that AI, while it's fascinating, it's less dangerous to you and I in our psyches as 50-plus-year-old men that have already gone through what we had to go through to get here. We didn't have cell phones. We didn't have, video games. We didn't like there is today. So that's my issue. Is I think that it's deteriorating components of humanity because of the quickness and the access of information.
Yeah, no, that's really well put. I think kids today, they're using spell check and they don't even know what to pick because they don't know how to spell anyway. They're just picking the first choice that comes up, and it's like changing what they're writing into nonsense. It's like they're not learning any of the fundamentals. But
is there anything that you can give out or talk to our listeners about listening to the show that JB Consulting is doing that you think is pretty exciting coming up?
I think we're always doing something exciting because I'm a big nerd. I love this stuff. But no, absolutely. I think we're greasing the wheels of where data flows and goes between both, the pharmacies sending it, but also the companies who are receiving it. Behind the scenes, we've always just been helping grease those wheels and making that better, but we're seeing more seeing really connection between the entities through the data share. So it's not even as much like data and telling a story, but see if we can't use that technology to really connect pharmacy to pharma, to the health plan, to the provider, and really seeing like that ecosystem be built that, interoperability promised us for the last few decades. It's kind of like behind the scenes on the data share side. Seeing companies coming to us for the first time, they don't just want the data, they want to know how to use that to establish the relationship and create that bridge and that plumbing that'll really connect this ecosystem. And there's companies trying to build the whole ecosystem, and we can go on forever about that. But no, it's an interesting thing. I think, connection is coming out of the interoperability, and that's what we're kind of seeing people coming to us for. So stay tuned. It'll be cool to see what happens.
All right. JB Consulting Group, Shaun, Jensen, thanks for being on the Asembia 2026 show.
Yeah, thank you for having me, Todd. Pleasure as always.
Hi, this is Lindsay Greenleaf with ADVI Health, and you are listening to the Pharmacy Podcast.
Lindsay, welcome to Asembia 2026 post-podcast press coverage show. We're so excited to have you here.
Thanks for having me.
All right, so you've been extremely busy here at Asembia. You were on a panel discussion on a subject that we have not tackled yet on this show, so we're so excited that you're here. IRA,
Yes.
Inflation Reduction Act, and the Most Favored Nation, and Trump RX, and blah, blah, blah. If you don't have the right people talking about these things, it kind of gets lost in the weeds. So talk to us about this from your perspective, your experience, but also this panel discussion. Talk to us about how this went.
Yes, it's a lot of acronyms in our world, in the policy market access world at ADVI. But on our panel, we talked about the biggest policy issues facing manufacturers, most notably started off with MFN, Most Favored Nation drug pricing developments coming out of the Trump administration. Talked about the latest status with, we now have 17 companies that have these voluntary deals with the White House. They're volunteering to give Most Favored Nation pricing to most, if not all, of their drugs in Medicaid and for new launches. We talked a lot about that, the implications that's going to have for ex-US launches or the lack thereof. Also talked a lot about, as you said, the IRA, the Inflation Reduction Act, government negotiation policy. This is the law that passed in 2022 under the Biden administration to impose what folks will often refer to as Medicare negotiation or government negotiation of drug pricing. I like to refer to it as government price setting. It's not much of a negotiation process, but what we talked about today is the status of the negotiation program. As of today, there are 10 drugs, 10 pharmacy benefit drugs in Medicare Part D, subject to a government-set negotiated price. What's going on with them? How's the Part D effectuation going, the effectuation for the pharmacies themselves, and what's going on with the other negotiations for IPAY, what we call IPAY 2027 and IPAY 2028. These are additional drugs that will be subject to a negotiated price starting next year and 2028 onward. So spoke to our panelists about all of that. One thing that was interesting that we got to talk about is the patient perspective of the Inflation Reduction Act and what's going on with these drugs subject to a negotiated price right now. Our team at ADVI, we have a data analytics team, ADVI Saves, that has access to 100% Medicare, Medicaid claims data. They did a quick analysis for us before we came out here to Asembia, looking at average out-of-pocket costs for patients taking the 10 drugs that are subject to a negotiated price right now. They looked at their costs for Q1 of 2026 compared to Q1 of last year. It was interesting. On average, patient out-of-pocket costs are only about 6% lower across all 10 drugs. You go through this whole negotiation process. The manufacturers are taking a big hit financially. And you're getting 6% on average of out-of-pocket savings. That was an average. That's an average number I'm giving you. Imbruvica, I would note, patients taking Imbruvica are worse off under this scheme. They, on average, their out-of-pocket costs for Q1 of 26 were 12% higher than they were in 2025. So the panelists reacted to that. They had gone through the negotiation process themselves and working for manufacturers. And sadly, they weren't too surprised. Some of this we knew would be coming. Plans, PBMs, they're kind of, shifting benefit design, having fewer drugs be on a copay model, have them switch to a co-insurance model. Everybody's kind of squeezing the balloon from different directions. But I think of all the things we talked about on our panel today, that was just one interesting data point, that the idea that patients are not all that better off and some are worse off in 2026.
All right, so this is not good news. So we really appreciate you depressing us on the podcast. No, I'm just, okay, you have the data, you have this information. When you look at everything, is there a red flag somewhere to say, here's the issue that's keeping us from not driving pricing down? Like, what's the issue? What's the barrier?
Oh gosh. Well, we talk a lot about need for more PBM reforms, and President Trump talks all the time about cutting out the middleman, and you see what's going on with Trump Rx and the focus on these direct-to-patient programs and cash pay generally, and how GLP-1s are changing things. So I think, generally there is this theme of taking a closer look at the role played by middlemen, quite frankly, and PBMs. Not everything is appropriate for a direct-to-patient program. Not everything is appropriate for cash pay, obviously. So what else can we do here? We need more substantive reforms on the PBM front. Congress enacted some reforms in February of this year, things that we've referred to as delinking PBM compensation from rebates in Medicare Part D. Then mandating rebate pass-through for commercial plans, and also some transparency requirements. That's notable, yes. But as we talked to our panelists about today, and folks that we work with are telling us, is it really going to change all that much? Maybe, probably not. It's really hard to have significant, notable change that's going to take down drug costs while also helping patient access when you have 3 PBMs controlling more than 80% of the market. No one has enough leverage to really go up against these guys. So I think unless and until we really address that consolidation, and it's not just with the pharmacy benefit managers, it's the fact that they're also owned by the health plans who also own a lot of pharmacies. It's a real squeeze on manufacturers, patients, and I know a lot of the independent pharmacies that you work with. So to me, consolidation is the piece that has to be addressed for any of this to change.
So, are you a lawyer too?
I am.
You see, that's nice. That's the right answer. That's what I wanted. All right. So when I look at this, I've been observing the pharmacy care market for 22 years. 15 of the 22 years, I finally understood kind of what a PBM is. Now it's ultra focused because we have data and Antonio Chacha and his crazy band of merry men from Access, three Access advisors, and now Congress is Jake Auchincloss from the great state of Connecticut is a rock star, and he's beating the crap out of them. Then we have states like Arkansas and Tennessee who are saying you cannot own pharmacies and be the insurance company governing that. All right, when I look at all of the marbles swirling around in the world of PBM reform, the most evident one at the CMS level is to say you cannot be an insurance company and govern pharmacy distribution and care through pharmacies that you own. That's completely what's Stark law, or that's whatever. Like that doesn't make any sense. That you are the insurance provider, the person that's controlling the money, and you're the outlet of services. And by the way, you're favored. You're favoring. Even with favoring their own pharmacies, Aetna, CVS Health, and the whatever, even some CVS pharmacies are getting closed down because their own model sucks so bad that they can't even keep their own pharmacies open, let alone Rite Aid collapsing, let alone Walgreens collapsing, let alone independent pharmacies collapsing. Why, in your opinion, isn't it happening at the CMS level where they're like, dudes, if you own an insurance company, you cannot own the pharmacy too?
It's a great question. I am going to look into this. I do not have a good answer for you. I would imagine CMS may or may not have authority on that. I'm trying to think under what authority they could regulate that. Is it under
FTC maybe?
Yeah, maybe the FTC. But thinking of CMS though, maybe it is network adequacy requirements. Maybe there's something there, and I hadn't thought about it like that. There is the FTC. The FTC has been active. We had been waiting for a very long time to get a response on what's going on with these lawsuits, the insulin lawsuits against the big three. We have this FTC settlement with Express Scripts that came out. It came out the day after Congress happened to enact some reforms on PBM. So it was a very big week for us consultants on PBM reforms. The Express Scripts settlement with the FTC is notable. It requires Express Scripts to do a number of things that would be helpful and that folks want. A couple things like not preferring a high WAC price drug over the same the generic or biosimilar that has a lower WAC price. New transparency requirements, things around passing through rebates, et cetera, et cetera. There were notable things in there, but the big catch is they mandate that Express Scripts make this part of their standard offering. And then employers and health plans have the choice of do they pick it or go with some other custom model that they're already doing. So whether you're pointing the finger at the PBMs or the employers and the health plans who keep demanding to keep the old model in place, it's kind of who are we pointing a finger at? It's helpful. I'm kind of a simpleton on these things. I just want someone to wave their wand and say, we can't have a company that's this big. I mean, to your point, make it as simple as you can't own the pharmacy and also be the insurer. Right. It seems so simple to me. The FTC is active. They're doing things. It's just they're not addressing that, what you and I are talking about. I wish they would go big, and I wish they could, and maybe they need more direction from Congress in order to do all of these big things, and getting Congress to do things takes an act of Congress. I know.
Yeah.
But I really think it all comes back down to these consolidation issues, because otherwise we're just chipping away at bits and pieces of this, and meaningful reform is just not going to happen.
So ADV is extremely involved in all of this data analysis. Do me a favor, promise to come back on either the This Week in Pharmacy, which is our weekly show, or maybe the NASP podcast, which Sheila Arquette is our host. But promise to come back and talk more to us from the ADV perspective, because I find it fascinating.
I would love to. Please have me back.
All right. Thank you, Lindsay.
Thank you, Todd.
Take care.
Magnar Kvilhaug with Odin Pharmacy Innovations. You're listening to the Pharmacy Podcast.
Magnar, it's great to talk to you again here at the Asembia show. How are you?
I am well, and you? How's it going?
Very good. This has been a busy show, one of the busiest that we've ever been at, but it's exciting time, and I can see how so many things are changing. Cell and gene therapy attention, 180 different medications that may be coming out over the next 12 to 18 months. AI in pharmacy, women's health. Like, there's so much happening just in specialty. Share with us what's been going on in your neck of the woods.
Well, thank you. This show, as always, is a great show. You can see what's actually happening. Historically, we've done pharmacy builds, improvements, turnaround times, payer clinical issues, and recently I've just expanded with HEOR and got some activity going there. And it's been a great year, and just coming here just to see what's going on. And to your point, there's a lot going on here.
Very much. Very much. So, talk to us about some of the projects and some of the things that you've been working on, and how it impacts the future of specialty pharmacy.
Well, I think that it's everything old is new again. It's all about getting the patient on board. What is the experience with the getting a patient onboarded? We have the list that is perpetually there: PA, turnaround time, friction within the system, access to network access. But when you just break it down and compartmentalize and stratify the patient, stratify your payers, and really plan your work and work the plan, that's where there's game changers.
That's incredible. How are you using artificial intelligence in your operations, and how is that impacting the most important person in healthcare, which is our patients? Yeah,
and not only using it as a user, but here at the show, we've got a lot of vendors here utilizing AI. And what we're really seeing now is AI is stretching from in the EMR, with the prescriber, through the hub, through the specialty pharmacy, and it is just bundling information, reading PDF, reading non-data, reading the PDF, creating the data, and it's just amazing. Now, on a personal level, yes, you can use these AI tools, and every pharmacist listening should be using, take your pick, the Open ChatGPT, Claude, any of them, and it's just amazing what you can do. Anecdotally, last week, I had to get some data. Unfortunately, I couldn't get an export from the platform. I had 3 years of data, monthly data, 36 individual PDFs, and just asked Claude, can you pull this out? I want this. I want it sorted in this way in an Excel, and out it popped. Took a few minutes to prompt, then a few minutes to come back, but it would have been 2-3 hours. It could have been a day or two wasted just with manual data entry. So it's a game changer, but the platforms, I think, are really going to make a difference where you're getting the entire information on the patient. Is this a naive patient or an experienced patient? Yeah. Those are two different patients.
I really appreciate the fact that AI is in specialty and in healthcare is being held to specific standards too, where they're starting to develop standards to hold things in check. So there's guardrails. We don't want obstacles. We want a guardrail in place to assure that it's just not run amok, and that your AI is adhering to some kind of standard.
Absolutely. And the exciting thing is here, there's a lot of AI companies here at Asembia. At various parts in their experience, like a few years old, others longer. But the nice thing is, here you can sit, talk with them, and then just watch and see who the winner is going to be, which is the exciting thing.
Magnar, we appreciate you being part of the Asembia 2026 post-show, and we hope to have you back next year.
Fantastic. Always a pleasure, Todd.
Thank you.
You do such a great job. Thank you.
The podcast press coverage of the Asembia 2026 Summit is brought to you by Paragon Pharmacy 360. Powered by the innovative Modesto Health Platform, where specialty pharmacy meets real-time patient intelligence. Paragon 360 is redefining pharmacy care by combining high-touch clinical support with advanced digital health technology. At the center of this model is Modesto, a clinical intelligence platform that works for both the care team and the patient simultaneously. On the clinical side, pharmacists get a unified patient record, auto-generated care plans, and real-time insights that automatically surface at-risk patients before gaps in care occur. On the patient side, automated and event-driven engagement keeps patients informed, on therapy, and directly connected to their care team from day one. No manual outreach required. The result? Less manual work for clinicians, fewer gaps for patients, and clinical data that gets smarter with every interaction. This unified ecosystem closes critical gaps in care, accelerating time to therapy, improving persistence, and delivering measurable outcomes across specialty and chronic conditions. But what truly sets Paragon apart is its ability to bring the pharmacist directly into the patient's daily life, turning insights into action and data into better care. As specialty pharmacy continues to evolve, Paragon Pharmacy 360 and Modesto are leading the way, bridging technology, clinical care, and patient engagement. Learn more at paragonpharmacy.org.
This is Marina Allen with RxAccess Partners, and you're listening to the Pharmacy Podcast.
Marina, welcome to the Asembia 2026 post show here at the Podcast Press booth. I kind of just named it the Podcast Press booth because nobody else has press here as podcasting.
I know, I love it. Thanks for having me. Great.
So, you've been to Asembia a bunch. So, why do you invest in coming to this conference? What is it about Asembia that you like?
Wow, I've been coming to Asembia for about 10 years, I'd say. I was on the pharma side for many years. I started in pharma in 2000. And
you feel old yet?
I'm starting to become an Asembia vet from back in the days.
Were you here when it was called Armada Health?
Armada Health, yes, absolutely. And they used to even pay people to come to these events versus, now we pay big bucks to be here.
Exactly. That's wild. All right, talk to us about RxAccess Partners. Talk to us about what you do and why you're focused on specialty pharmacy.
Well, we are a market access and patient services consulting firm and marketing agency. We're not your traditional market access consulting firm or agency. We actually do a little bit more, I would say, in the realm of what differentiates us as patient services. We do all your traditional market access consulting, strategy, market research, payer ad boards, all of that. We also do the marketing as well, so we can build all their PI decks, PVP decks, anything of that nature. And then when we move over into the patient services realm, we can really, from RFP through design, build, implementation, we have a team that can help design, build, implement patient support programs. We've are senior-led, I would say. Everyone's 20 plus years in the industry, so it's not that typical, you've got the seniors as maybe the client leads, but then you've got the juniors doing the work that've never done it before. Mm-hmm. So we truly are senior-led, where everybody's been in the shoes of either the manufacturers or life science clients, as well as, really working in the industry for a long time in many different facets. I feel like it's been putting together a very large puzzle together. There's 20 plus of us nationally. We have a whole creative department too that can do all the access marketing too, but each person's a different piece to the puzzle that has very unique expertise, I would say.
Now, do you pick specific disease states or conditions that you've had success on, or it really doesn't matter, just it's up to the scenario?
Really doesn't matter. Everybody, all of our consultants have all different breadths of experience, right? Rare disease, oncology, specialty, pharmacy benefits, right? Like we've had all of it, so it just really depends on what client comes to us. Anything with access related, a lot of it just comes to the process in which we need to look at it. But no, we really can. each one of us has a specialty we like, you know. Rare disease, there's a few folks that really like to specialize in rare disease. Oncology, we have a breadth of experience in oncology as well. Cell and gene therapy, immunology, you know. Any of the complex specialty products, those we've done a lot of work in, because, you know, when you work in both market access and patient services and really building those patient support programs that have those more complex patient journeys, there's a lot more that you have to do in that world. So
what challenges are in place that you recognize in your consultancy space that you're like, this is really impeding access, this is really impeding and creating issues for the patient? Like, what component of the ecosystem of specialty is still the bane, like is still the issue?
Well, getting coverage for those patients, right?
Exactly.
I mean, the prior authorization process and what the payers put in front of the providers' offices and everything that you got to do for that. I would say that's one of the biggest in making sure that they're recouping reimbursement as well. A lot of these specialty drugs, the offices or providers have to pay for the drug up front, and they're barely reimbursed for what they're paying for the drug. So the margin is so small, and the errors can be so big, right, where they're not getting that reimbursement. So from on the front end, getting it covered and getting that authorization, and on the back end, making sure they're getting paid for when they did get the authorization paid covered.
Absolutely. It's the ability to get the barriers out of the way to get them on the medication and get it approved through the prior authorization and everything, and then keeping them on the medication, because if there's an insurance change or there's a formulary change, there's so many things that could happen to prevent care from continuing and treatment to continuing. And that's where I think organizations like yours are coming in to kind of say, listen, we've seen this 100 times. Let's look out for these pitfalls.
Absolutely. Yeah. And how do you decrease the time to therapy, right? I mean, some of these patients are very, very ill, and waiting 2 weeks for a prior authorization is just not very doable. So how do we help those processes become more efficient by educating not only the manufacturers, the providers, and from all the way to execution in the field, where they're able to educate the patients and the providers.
Marina, I really appreciate you taking time to be part of the Asembia podcast press coverage 2026. I hope to have you back next year.
Absolutely. I'd love to be back.
Thank you.
Thank you.
Hi, this is Matt Hare, Vice President of Network Growth at CoverMyMeds, and you are listening to the Pharmacy Podcast.
Matt Hare, welcome to the Asembia Post Show covering Access to Pharmacy 2026. How are you?
Doing great. How are you, Todd?
I'm great. It's so good to see your name show up on our interview list. CoverMyMeds, I have watched this company go through so many different transitions and joining forces, and it's been all focused around pharmacy care. So let's talk specialty. We're going to shift the gear. I want to dive in. This is really what I'm curious about. How digital health and artificial intelligence, how is that shaping the future of specialty workflows and care delivery? Kind of give our listeners an overview of that.
Yeah, absolutely. If you think about specialty workflows in general are very complex. The patient cases are very complex. A lot of questions, obviously, about their care. And so as clinicians spend time with their patients and they develop a care plan, they also have to think about, how do I get my patients on medication? How do I keep them on that medication that's going to make them healthy? And so really the tools that are available have evolved, to your point, so rapidly. And so as clinicians think of need to get this patient on therapy, but also start to think about other things that are happening with the patient, leveraging tools like automation and AI is something that's critical. The other thing is, I think a lot of patients feel at times that potentially their clinician will have their back to them or are doing work while the patient's in the office. And so being able to leverage these tools also lets them bring some of that humanity back to care. And so that's something that we hear a lot about, is how do I spend more time with my patients and leverage the tools that are available? And so it's very exciting. I think there's a lot happening right now. And so I think what we hear from a lot of our clients is what's really going on with some of these tools and how do we leverage those appropriately?
I'm starting to feel like the old guy in the room. I've been around now. We've been doing podcasting for 17 and a half years. We've covered this event when it was called Armada Health way back in the day. And AI, when we first started hearing about this 7 years ago in pharmacy, it was kind of like, you'd say AI and you didn't really sure what you really meant. Now it's the real deal. Now it's literally embedded into everything. So let's talk about this. AI in becoming more practical in specialty pharmacy, rather than focusing on AI as a broad trend, the discussion's turning into intelligent automation. Tell our listeners what that means through CoverMyMeds.
Yeah, absolutely. So we believe that whatever tool you have, so think about an EHR, there's a lot of information in that EHR and being able to harness that, but also not having the care team have to comb through the chart while they're trying to get a patient on medication. And so what we see is you can leverage AI, and to your point, it is here, and being able to use that to start to pull information and service up potential recommended solutions or answers to questions for prior authorizations through the chart. And so rather than staff having to go through and comb that information, it can populate some of the potential answers for some of those questions. And so that's something that we're hearing a lot about, is it's saving me so much time. And that's the one thing, and kind of going back to my earlier point about spending time with the patient is really important. These are very critical cases in many instances, and so being able to pull some of that information to the forefront gives them peace of mind that, yes, I'm still being able to spend time with my patient. I'm a clinical expert, but I also have these tools that are helping me surface that information, and so it is very, very cool.
So part of the richness and the secret sauce of CoverMyMeds is pulling multiple things together for our providers, for our pharmacists to not have to spend time on those tedious tasks and doing what. So digital health is helping. Speak to the broader shift towards more connected care delivery. Where does that technology support coordination across, we're talking providers, pharmacies, health systems, your partners? Talk to us about the connection.
Yeah, absolutely. I think that is the critical piece of being able to have all of these stakeholders that come together in patient care. Right now, in many instances, our users are having to go to disparate points of contact, and whether they're going out to an outside portal or they're going out to another website, really bringing that into a single solution is critical. And to your point, if you're seeing a dozen patients a day, one might go to a different pharmacy than another, they might go to a different clinic, and so how do you bring tooling that will connect all of those stakeholders is absolutely critical. And ultimately, at the end of the day, this is about getting patients on therapy quickly and giving them the peace of mind that they have that. And so that connectingness is absolutely critical to doing that.
So one of the biggest obstacles in specialty pharmacy, and the reason why specialty pharmacy is so special, is the workflow also includes the prior authorization, which can always be a barrier, especially if insurances are changing, bin numbers changing, something changing. It all comes back to that, I want to say, the poor pharmacist that has to put up with all of that.
Absolutely.
So CoverMyMeds really helps to get rid of those barriers. So talk to us about access, affordability solutions, bringing together the capabilities across areas such as benefit investigation and in prior authorization.
Yeah, absolutely. So CoverMyMeds, and you kind of hit on it at the beginning. I've been here 10 years, and so seeing the evolution of the business.
Are you an old guy?
I pretty much am at this point. Yeah, and so really starting with pharmacy benefit, and we were able to solve a massive problem, to your point, of bringing all that information together into a single solution. One of the things we've been asked from our clients is, what about medical benefit prior authorization? What about enrollment capabilities? And so with our specialty affordability and access solution, we are bringing what we did in the pharmacy benefit space, and now having pharmacy benefit prior authorization, medical benefit prior authorization, and enrollment capabilities. And really the intent there is, whatever barrier there is in preventing a patient on getting on medication, trying to solve that in a single instance. One of the things we've heard from a medical benefit standpoint is I'm going to 10 different websites and manually entering information, and so it's not acceptable. And so being able to find a way to solve that is something that we think is one of the most important challenges in healthcare.
All right, let's talk about the future. I love that word. I've been a science fiction buff my entire life, but I like when it becomes reality instead of it just being science fiction. We don't want science fiction in medicine. We want the real deal. So with that connection, a strong area of specialty pharmacy that looks like digital health and AI could become more embedded and more connected to the patient. Expand on that for us. Tell us what that means for using and being partnered with CoverMyMeds.
Yeah, absolutely. I think there is going to be an expectation of everyone, patient included, that there is going to be technology that's going to help facilitate all of these barriers and challenges. And so I think you're going to continue to see more connecting this and leveraging technology to accelerate patients getting on therapy. And so I'm very excited about it. I think one thing that is just really important to keep in mind, the intent is not to displace the clinician. They are the expert, and making sure that they have the tools that are in place to help them do that. You're going to continue to see that, and I'm very excited about it.
So the typewriter did not displace the pharmacist. The computer did not displace the pharmacist. The data warehousing did not. I could just keep going.
Yeah.
AI will not displace the provider, the pharmacist, the person that's signing off on that care. It's a tool.
Yeah.
It's not to replace. It's to enhance. It's to make that pharmacist more connected to resources and to information to expedite care, because that's the important thing, is get these patients on their medications, and let's keep them on their medications.
Absolutely.
Matt, thank you so much for being part of the Access to Pharmacy 2026 here at Asembia. This has been wonderful.
Thank you so much, Todd. I really appreciate it.
Richard, Brook, becoming a regular at the Asembia podcast coverage here. This is the 2026. I can't believe, Richard, here we are again.
It's an honor to be here, Todd. Thank you so much for sharing all the things that we do with our community.
Absolutely. I take great pride in getting this information out, but I like talking with the innovators. I like talking to smart people, and that's why I like having you back. Better Health Worldwide is an organization you started. How many years ago has it been now?
So we've actually been in business this is our 26th year.
Oh my goodness.
Although we, for many years, worked under the radar with other people. A lot of times we work for pharma device manufacturers, and it's really about promoting their work to the patients and the insurers, not necessarily our work.
So you attended a session. I wasn't able to attend because I've been stuck in the podcast booth all day with the coverage. But something really interesting is how employers have an opportunity to protect their employees and the benefits that they're providing. Would you expand around that session and kind of like from your own insights about that?
Sure. Well, I don't want to take other people's thunder and talk about what they talked about. I actually want to talk about what they didn't really talk about. In 2021, there was a legislation, CAA 2021, which put a fiduciary responsibility on employers to not harm their employees and do the right things with their insurance. And I think we oftentimes run into a difference between what an employer would like to see and what an insurer would like to pay for. And we think this goes in many facets. We're always interested in making sure of treating our employees so they can get to work, so that their family members don't keep them from working if they're a caregiver. God forbid your spouse or child has a disease and you have to take time off. We have family medical leaves and other things for that. I think we're the only company that actually tracks family medical leaves across a number of industries. Today's session, though, was very interesting to me because their big focus was on net to zero rebates. Now, granted, we were at a meeting for specialty pharmacy, and we were talking about specialty pharmacy drugs and net to zero rebates. The importance of outcomes came up, but certain outcomes just don't come up, like absenteeism, caregiver impact. Again, if your spouse is sick, can you take time off to go to work, or do you have to do other things with your life? Family is important. And one of the things we're always looking at are some of those medicines that'll improve somebody's life, allow them to function not have to have a caregiver drive them somewhere. These are things that are important to us, but they're actually a cost to the system. And it's interesting to me that employers actually, we always hear that Medicare, Medicaid, and the government are the biggest payers for healthcare. But if you do the math, it's actually all funded out of employer payroll taxes. So while our employers are actually paying the insurers and other people to do things, the payroll taxes that they pay fund Medicare, they fund Medicaid, they fund a lot of these other programs, and it's sometimes a shame that we're not getting the right care we would have. While not a full specialty product, but there's been products over the years to treat influenza, and the cost of that product might be prohibitive, but the data showed that if you took this drug when you had the flu, you could actually go back to work without getting everybody sick. And a lot of insurers said, well, we don't want to pay for that because now we have to pay for a medicine. And the downside to the insurers not paying for the medicine is, well, they're not going to work. Well, they don't pay for that. And in 1% to 2% of the patients, they would actually land in the hospital where they did pay. But I think a lot of the insurers were willing to roll a dice there. Roll a dice. Hey, I guess we're in Vegas. I think it's really important that we really focus on keeping people healthy, getting them able to work, making sure if they're in that caregiver role for their family member, or even for not a family member, but that they're able to do what they need to do and feel comfortable in that situation. Does that make sense?
It does. It does. So when you come out of that session and you start adding in some of your own thoughts, how does that tie back to specialty pharmacies executing some policies in place to keep that patient at the center so that we're not, once again, getting pulled back into the profit over people, that we all know that that's real. We're not naive enough to think that that's not happening, in a lot of places.
We're all in business, whether you're a specialty pharmacy, a patient assistant group, the pharmacy podcast, or even our research organization. The goal really, though, is to make sure that, we get the people the right medicines for the right patient at the right time, which makes me think of, one of the other themes we keep hearing about is how GLP-1s are the biggest growth area that we see. And we just published an obesity paper in the American Journal of Managed Care, this month's issue. And employers have been one of the few groups that have traditionally covered obesity medicines. Now we see some movement in the Medicare space there. And what's really interesting to me is with this new trend into direct-to-patient sales, the way the process is going to work is you're going to call in, they're going to give you a prescription, which then they're going to fill and ship to you. But that prescription that goes through their phone systems, through their doctors or their physician assistants, probably is not going to be recorded on your medical record. The purchase of the medicine, because there's now no medical claims, the health insurer is not paying for it, probably is not going to show up on your medical claims. So when I do a study looking at a control group of people who could have obesity meds versus people who did have obesity meds, my control group needs to really be thought about, because now they might actually be taking obesity meds through that direct-to-patient channel. So we're starting to build processes to check for that. We haven't figured out how to break the coin here or how to identify every one of those patients, but I think it's something as an industry we have to go with this new model, because it's not just going to be obesity drugs. We heard people talking throughout the meeting about other classes of drugs that are going to be ripe for this direct-to-patient model, and what we really need to figure out is if that's happening, how do we track it? Especially if an employer says use your deductible to pay for that medicine, well, what does that do to the rest of the things in the health insurance benefit?
Right, exactly. That's a really good point. What about Asembia has been either surprising or has been inspiring or has been interesting to you? What technology, something in AI, what has really stood out to you that you think brings a lot of positive future look at the industry?
Well, I don't think you can go to a session at Asembia now and not see AI somewhere. Whether it was AI curated my slides or AI wrote my slides, I saw somebody present the other day. I think the big challenge is needing to keep the human factor in there. Just because AI came out with this answer doesn't mean it's right, and how do we make sure that it's going to be correct for our particular purposes? So AI can help us get to a destination, but did it get us to the right destination?
Great. I like that. Richard, Brook, I appreciate you and your insights here on the Asembia 2026 post show. I can't wait to have you back. I want you on This Week in Pharmacy, so I'll be following up with you to do a special segment of This Week in Pharmacy.
We'd love to work with you guys, Todd. Thank you so much for the opportunity.
Hi, this is Colin Banas with DrFirst, and you're listening to the Pharmacy Podcast.
Colin, this has become a tradition where we show up together and meet up at Asembia for the Asembia post show. This is terrific. How are you?
Good. Thanks for having me.
Hey, you brought a colleague with you, Valerie Mondelli, pharmacist, which you're my favorite provider, by the way, Valerie. You probably didn't know that.
Thank you, Todd. Well, we're accessible, and certainly we love our patients, so appreciate you having us.
The most accessible. I also know that with pharmacy deserts and closures and complexities, it's making everything that much harder. So data is so important now, and specialty medications have that high risk abandonment situation with people may not even start the prescription. They might stop it. It just wrecks everything in within the therapy. I'm going to start with you, Colin. What keeps patients from filling their prescriptions, and how does DrFirst help?
Yeah, well, the prescription non-adherence is multifactorial, as you would expect, but I tend to put it into sort of big buckets of when I'm categorizing. I'd say one of them is the education bucket, so patients often don't understand how important the med is or what to expect or what sorts of side effects there might be, and so you can never over-prepare or over-educate your patients. I think the second one is probably the most sensitive, and that's the price bucket, the out-of-pocket bucket. And there's a lot of problems in the current system today in terms of the transparency of the whole process, and so the patients often don't know what to expect. Go to the pharmacy and then get hit with sticker shock. And so how can we help them overcome that barrier? And then the third one is often patients just forget. Life gets in the way. Pharmacists know this just as well when they have to reshelve something because it's been sitting there for 2 weeks. So how can we give our patients gentle nudges to help overcome all three of those barriers?
So Valerie, as a pharmacist, someone who's in the midst of all of this, you're like the hub of everything. You're caring for the patient, you're following up. Sometimes the patient's family has questions, obviously the physician. Talk to us about the network importance and how DrFirst fits into this and how it actually helps to keep this whole process flowing.
Todd, I love that question. First of all, I don't practice anymore, but I certainly was behind the pharmacy and the counter, and when I would help patients try to start their therapy, it left quite the impression on me with what they go through and the friction that sometimes they experience. And so what DrFirst has been able to do in our platform is really be a prescription engagement for both the provider as well as the patient and the pharmacist to kind of bridge the gap. Once they leave the doctor's office, it's intimidating. They've just experienced maybe something, they've been diagnosed with diabetes and they now have to inject themselves. And how do you educate them, but also how do you get them to the pharmacist to pick up their therapy to start and stay on it without being fearful? And part of that is education, but also part of it is the financial assistance that Colin referenced. I think a lot of times patients think that they can't afford therapy, so why would I even bother go and pick it up? It's just an intimidating process all the way around. So what we try to do is bridge the gap from the prescriber to the pharmacy for the patient, so that they have a coordinated experience between the two, and that they're not alone. And I think it really makes a difference, just that those nudges, but also the education and the financial options that we really display to them before they even get to the pharmacy.
That's awesome. I appreciate that from the pharmacist's perspective, because you see it from the patient's perspective. You see it through the patient's eyes.
Exactly.
The bane of specialty pharmacy, in my opinion, Colin, is the prior authorization. How's DrFirst implemented into this ecosystem to loosen that up?
Yeah, DrFirst is in a very unique position after 26 years in the industry, having relationships with the prescribers, the patients, as Val was just talking about, the pharmacies themselves, and even PBMs and pharmaceutical companies. And so because the specialty prescribing and adherence process is so complex and there's so many different players with so many different sets of rules, for lack of a better term, what DrFirst does is sit at the very point of the prescription's inception and understands all of those key players and all of those key rules so that we can influence and guide and assist the prescriber to get what I call a clean script out the door the first time. And when I say clean script, I don't mean it abides by the NCPDP standards and it makes it from point A to point B. A clean script is one that doesn't come back to me, that doesn't get a phone call, that doesn't get a fax. A clean script is one that Val and the specialty pharmacy can fill without additional effort. And the way to do that is upstream where the prescriber sits, understanding all of those rules, and then packing that data into the script itself. So sometimes it's as simple as an ICD-10 code. Sometimes it's answering 3 simple questions that the doctor can just bang out right there. And we use AI to predict those sorts of things so that we can create that clean script, because the best PA is a PA that I don't have to do, and probably the pharmacy doesn't want to do it either. So let's move the whole thing upstream and just get it right from jump.
All right, Valerie, now downstream, DrFirst is closer to the patient than ever before with some of the new communications tools. Tell our listeners about some of those tools you guys have in place.
Yes. When they leave, as Colin was describing, after the script is clean, I can fill it. The pharmacist can fill it. They can focus in on really what they love to do, which is clinical services, right? To really try and spend their time not having to do all of the work on the insurance part of it, fixing the prior auth, calling the doctor back, having all that work to do. Let's focus on getting the patient started on their therapy in the right way. And they can spend their time on clinical services, teaching the patient how to inject, making sure that they have their vaccinations, that they're up to date on all of their medications, that they have the time to really answer the questions and help the patient to have a better, healthy outcome. That's really what we're trying to do, is take all of the administrative work out of the process so that it's clean and it's a win-win for everyone.
Colin and Valerie, I want to thank you for sitting down with me for the post-show. It's always a pleasure catching up with you, Colin. I've watched your career for over 12 years now. It's just amazing to watch how far DrFirst has come to, and the technology in place. We need more and more of this to make things easier to access medications, to get on medications, to stay on medications. Thank you, and a shout out to DrFirst and your team for being part of the show. Thank you.
Thanks for having us, Todd.